Well, good morning or good afternoon, everyone. This is Joy Burkhardt with 2020 Mom. We're so glad to have several of you with us today and others who will be listening to the recording later. We're pleased to present today the first in our series of our Innovation Award winners. And today we're going to be hearing first from our Innovative Program and Care Award winner, the Poem Award, or the Poem Program, rather. And we have a special guest, Tanya, who is with us today. We're going to go ahead and move on to the next slide, and you can see our photos on the next slide here. So here I am, Joy Burkhardt, again, the Executive Director of 2020 Mom, and you can also see a picture of Tanya, who's with us as well, Full Wider. She's the Program Director of the Poem Project, which we're going to hear about today. We wanted to first introduce Tanya. I'm going to read Tanya's bio and also go over some logistics. We wanted to share that there's some great handouts that she has provided about her program that you can pull down and review from the control panel on the right-hand side of your screen. You can see the gray boxes and one that says handouts. And if you open that handout box, you'll be able to tell which attachments are included that will be available for you as resources going forward. So I'm going to go ahead and introduce Tanya, and also before I do that, one more quick logistical item is that we'd love to have you ask your questions throughout the program today using the question box on the control panel. Again, another gray box on that control panel. You can type in a question and we will be able to read them at various points during today's session. So I am pleased to introduce Tanya. She's the Program Director of the Mental Health of Franklin County and co-founder and director of the Perinatal Outreach and Encouragement for Moms program, the Poem program, which is receiving the award. Tanya is the Central U.S. Regional Coordinator also for Postpartum Support International, and she was the recipient of the 2009 Jane Honigman Award, which recognized her outstanding contributions to the goal of increasing awareness of emotional health related to childbearing. Tanya also oversees her agency's myriad of support groups, which you're going to hear a little bit more about today, the Get Connected program, all of the educational programming, and she teaches the de-escalation training and work-life balance training programs. She is certified in mental health first aid as a USA instructor, which we love, and she lives in Columbus, Ohio, with her husband and 2 daughters. Tanya, welcome. We're so glad to have you.
Thank you. Thank you. Happy to be here.
Great. And so some of you, I believe, actually have the pleasure of seeing Tanya present her program at the Perinatal Mental Health Society Conference in Chicago, where we had our winners share their work and got to know her a little bit better there. But many of you have not met Tanya before, so we're going to actually just start, Tanya, by asking you a question about what brought you to this work. Tell us what brought you to this work in maternal mental health.
Well, I think like many of us that I've met over the years in this field is my own personal experience. I have 2 daughters. My oldest daughter is a sophomore in college at Ohio State, and I dealt with perinatal mental health complications with her. And at the time, in the late 90s, in Columbus, Ohio, there were no resources. There was no one that could really explain to me or help me connect with appropriate care. So we took matters into our own hands. And so 19 years later, we're still plugging along here.
That's great, and you're right. We hear so many stories and champions who create programs based off their personal stories. So thank you so much for sharing a little bit about your story. So for folks on the line, when you hear about Tanya's program and the recognition that she's receiving and their program is receiving in the category of care, if you were like me, you may have expected maybe a clinical, clinical setting, an OBGYN office or a large hospital group to receive this award. And so it's really a great pleasure to get to have Tanya go into some detail about her program now and the fact that it's a community-based program. And Tanya, where I want you to start is first to tell us, when you first started your program years ago, how did you get started? Were you, did you immediately form a nonprofit? And then we'll move into, over time, how you decided to actually become a part of the Mental Health America organization in Columbus and Franklin County. So if you can just start by telling us a little bit about the start of your organization at the time and what it was that you set out to do and how you first got started.
Sure. So really the start was a support group, that in-person support group once a month. There was another woman who listed her home phone number that people could call and ask questions and find out when the meeting location was and that kind of thing. But that was pretty much it. Which again is better than nothing. But that's where we started. And then just as we continued to manage the support group, we learned more about, perinatal mental health conditions. We learned more about what a treatment picture should look like, what resources needed to be developed, what as a community program we felt like, was missing, or things that we experienced that maybe, we would have been helpful. So no, a nonprofit did not happen. I think we made the decision probably about 4 years after we really kind of delved into what what things look like, and it just the nonprofit happened because that we felt like that was the next step in trying to grow, was securing funding, looking at grants and other partnerships and that kind of thing. So that's where we went from there. I think there was a third part of the question, but I forget now.
Yeah, well, I mean, eventually, that you decided it was best to become a project of or a part of Mental Health America. Can you tell us a little bit about that transition?
Sure, absolutely. I'm happy to. So we operated as an independent nonprofit for about 9 years. No, I'm sorry, longer than that. But about 10 years, I guess. But and I think those of us who, really, I mean, I think in any business, but certainly, in the world of mental health or community programming, knowing the other collaborators in your community and that kind of thing is so important. And being and the then director of this affiliate of Mental Health America, we had conversations about the programming that this agency has and just different avenues for collaboration. And over the course of several months, we got to the place where it just seemed to make sense for both of us. The agency at the time was very interested in women's health as a whole, but given that we had developed this maternal mental health program, and we were going strong. It certainly wasn't. We were a financially healthy, independent organization, so there wasn't a need to merge. But myself and our other co-founder, I mean, we got into this work in order to provide support services. My passion was not filling out IRS forms and all the things that go along with managing a nonprofit. So the partnership really allowed me, and our other volunteers and staff to shift that focus, over to programming and growth versus managing a nonprofit. So a lot of that admin stuff came off our plate. Marketing things, went to the marketing staff and those kinds of things. And I'm happy to say that since we merged in 2013, our program budget has nearly tripled, just with new programming and new support and added staff, and it's been nothing but a really positive experience.
Well, that's fantastic, and we are going to highlight at some point, I know with some of your help as well, other Mental Health America chapters that are doing some great work in maternal mental health, but we're so pleased that it's working so incredibly well in several markets, including Franklin County. Thank you for sharing that transition and how you got started. Let's move into a little bit about the programming that you do offer. We heard a bit about the support groups that you started from the very beginning that really are peer-based support groups, and you can touch base on that in just a moment. But let me also highlight the other two, I think, core components of your programs that were so attractive to the judges on the Innovation Award panel, that this program really is very comprehensive, and that's why it seems to be working so well and have such good evidence base around it. So we talked a little bit about support groups. I want to hear more about that in a moment, but you also provide access to clinicians, in particular counselors, for the community, including serving women that have insurance and those that don't have insurance. And then what makes your program, I think, extra special, it's hard enough to provide support groups and counseling and figure out the financials around those services, but you also provide, through the help of Mental Health America, an Ombudsman Program that links the women in your community to other community-based services like housing and legal aid, and really are able to think about all of the reasons why women may be suffering and help to potentially address those mitigating factors that, if a woman doesn't have a place to live, all the counseling in the world, right, may or may not help. So touch on each of those three things, and let's start first with the Ombudsman Program, if you don't mind, Tanya.
Sure, absolutely. So this was one of the other huge benefits to becoming a program of Mental Health America here in Columbus. And the Ombudsman Program has been a part of our MHA affiliate for probably 17, 18 years. And, in theory, the people can refer to the Ombudsman anywhere, and they do. But having this Ombudsman Program really as one of our core partners in caring for women means that, our Ombudsman Program Director is the office right next door. We do we have a lot of conversations about what resources, that we can connect a woman to care to that's going to, what's that next thing? Just like you said, Joy, if she has housing insecurity, which is a significant issue, and I know it's not just here in Columbus, but everywhere, but it is a significant issue here. If she has housing insecurity, then probably the first step isn't getting her connected to a counselor. What is it? Does our ombudsman need to get her connected to a case manager? Does she have Medicaid benefits? Do we need to look at that? Do we need to look at connecting her with one of the navigators? Does she need to start in the shelter and then go from there? There's all those things, and and I have a partner in someone that can help do that. And even beyond that, she can help coach on, helping to navigate the case management system, legal issues. And we have a just last week we had, it's a client that started as a poem client, but we found out that she has an eviction hearing 9 days before she's scheduled for her C-section for her 4th child. So Leanne, our ombudsman, was able to connect her with a legal aid attorney who contacted the client that day, and was able to reach out and will help her navigate that, that whether it's going to the eviction hearing for her or with her or getting it moved or whatever, and that all happened within a couple days, and doesn't necessarily have a lot to do with mental health at all, but it's just working to really figure out what moms need and what we can do to help connect them.
That's
so everything.
Great.
Go ahead.
I just, before we move off this topic, I think there might be a couple questions that are coming in about it, and I also have another question. Were you finished with that train of thought?
Yeah, absolutely. We're centered around mental health, but it's really the social determinants of health that we try to look at the lens.
That's really fantastic, and I know so many people are trying to address this issue with that lens, and you guys are mastering this work. So let me ask you this: the Ombudsman Program, which you mentioned, Navigator, which I think is really one and the same, right? You might have 1 or 2 team members that serve as navigators under this program. Can you tell us a little bit about how that program is funded, and is it purely a project of Mental Health America, or is it also in partnership with the county, Department of Health? Or just tell us a little bit more about the program.
Sure. Well, our agency's largest funder is our local mental health board, Mental Health and Recovery Services Board, and so that board, the taxpayer-funded county mental health board, and they fund the POEM program. They're the largest funder of the Ombudsman Program, but as well as our pro bono counseling program, which is access to free clinicians for those who are either uninsured or underinsured. So the primary funder is for the Ombudsman Program is our local drug and alcohol, drug, and mental health board, and so she has a partnership with them and serves as that connection to resources for them. But we are also, like most nonprofits, have a diverse funding stream. So our local United Way, our city Human Services Fund. There's some other funders. But yeah, each program within the agency has its own budget and own funding stream that looks a little bit different. Hopefully that answers the question.
It sure does. Thank you so much for that. Can you tell us a little bit about how many women you are able to serve approximately on an annual basis?
Last year in 2016, between all of our programming, so I'm talking about getting people connected to resources, our mentor program, our support groups, we were about 671, so a little under 700 women annually, and it looks like 2017 will be around that.
That's great. And do you mind telling us a little bit about the breakdown around how many women might be on Medicaid versus uninsured versus insured on a commercial plan?
Sure. So the majority of our clients are Medicaid-based, a little more than maybe around 55% are Medicaid. I don't know the exact breakdown offhand between private insurance and uninsured. We do certainly work with uninsured, undocumented immigrants. Those situations certainly, it's a smaller percentage, but then a fair amount that have private insurance as well.
Great, good. Thank you for that. Now let's go back to the question that I asked several minutes ago, and then kind of divergent things there. Tell us a little bit more about both your support groups and how they've evolved over time. Are they mostly peer-led, or do you also have clinicians that that perhaps co-lead the support groups, and then the access to clinicians and how that works.
Sure. So as far as support groups, they are still all peer-led. We do a 2-facilitator model. Our facilitators commit to 1 quarter a year as a team, so kind of building that continuity, throughout each quarter, so that moms who attend multiple times get to know the facilitators, and we have a pretty a well-established training program. We actually originally modeled it after the Pacific Postpartum Support Society in Vancouver. Who's I'm sure, as you know, has been around since the 70s and has perfected a lot of care models. So we modeled our training program and our peer support group programming from them, so each facilitator has a very specific role, whether it's a lead facilitator or co-facilitator, and what those roles are. But we have a wonderful relationship with many clinicians locally. So we have kind of several who are on call as clinical advisors, as well as we have professional staff here at MHA. So it's lots of access to advisors if we need that, and any clinical questions come up. But the support groups run a couple times a month. We do also have a maternal mental health, which we define here as beyond the first postpartum year, only not in the technical term as far as that larger term, but as far as defining our group. So we have one group that's kind of for beyond postpartum, toddlers to teens. So we have about three a month, and then those are supported also by an online support program as well. So, well, like I said, they are peer run. They continue to be that most, if not all, I'd have to think about all of our volunteers, but they've almost all been through the POEM program, have gotten better, and then go on to volunteer. And we really look at that as our engagement loop and what sustains the program. That we, when someone comes to the group for the first time, we sort of lay out a vision. We give them several materials that lays that out. Here's what here's what support groups are. Here's what our vision for how this might help you. Do you need other resources? There's a whole host of things that we offer on that first time they attend, in order to hopefully engage them to work with us through recovery. And then if they so choose, then they can come back and train and volunteer.
That's fantastic. Really great work that you're doing. Tell us, before we move on to the clinical component, counseling and referral line. I know you also, besides having the group support groups, you also have this mom mentor program. Can you tell us a little bit about how that works?
Sure. So, in all honesty, the mentor program came about, it was the idea, and was maybe around 2007, and it was that our groups were growing, and we always like to kind of follow up and keep in touch and find out how moms are doing, and do they need resources and that kind of thing after, but the center of the program really was still the support groups. We just couldn't keep up. We couldn't keep up on calling women back and following up and seeing how they are and whatever. So how can we get some help? How can we, these women that are coming month after month that are getting better, how can we engage them? So that's sort of where the idea for a mentor program was born, is to, as we assess, complete an intake, a new mom that comes into the program, whether it's through support group or our program line or whatever, does she have a need for ongoing peer-based support? And so that's where that came from. It's a one-on-one. It is primarily phone and text-based, although we leave a lot of that, to the discretion of the mentor. Some will schedule a time to go take a walk in a park together, or whatever, but that is certainly not required. But it's basically another mom who's been through some kind of perinatal mental health complication, has recovered, has completed our training program, and provides weekly support for as long as the mom feels like that's beneficial to her and helpful to her.
Really, really great to hear. And okay, before we move into the clinical section again, I keep doing this to you, but another question about text-based support, and tell us how that works. I think you offer both telephonic support through the Mom Mentor Program and text-based support. Is there some sort of official platform that you use, or is it really a mom using her own cell phone and each has given permission? How does that part work?
Right. Well, so there's a couple ways we offer text connection. So our program line does also, women can also text just even at the very beginning of entering into the program, and that is that's just over a Google Voice platform. We don't disclose any personal health information over text. We don't offer any kind of identifiable information over text as far as that goes. But as far as the mentor program goes, yeah, that's a mom-to-mom program. It's not clinically based. Every poem client, and I use that word broadly, does give permission for the mentor to contact her and for her information to be released, and they give permission from the very beginning. Very beginning of our contact, we get permission from the poem client to use her information in whatever way is going to be beneficial to her, whether it is connecting her to a counselor, whether it's connecting her to a mentor, sending her an email with our support group times, that kind of thing. We do have a few, and we'll get to that as far as secure communication mechanisms for any kind of protected health information. Even though, as you said at the beginning, we are not a clinical program, we do follow, some HIPAA protocols on private information.
Great. I think that's really helpful. We'll see if anyone else has questions about that. You hit on the fact, but we haven't touched on it directly yet, but that you do offer, essentially a warm line, and it sounds like you use the platform Google Voice for providers, or at least patients, maybe providers, to call in or text in if they need support, and that might be the first door they come through to find you. Can you talk about the line directly for just a minute?
Sure. So yeah, I mean, if a mom, a potential client, a family member, whomever, they can certainly call that line. We do offer a 24-hour response window, so it's not a hotline, but we do respond to calls within 24 hours. If they get a voicemail, if we don't answer the line, they will hear that they'll get a call, back within about 24 hours, and they will also hear that they have the option to send a text, and we can text back and arrange a time to talk. That kind of hopefully eliminates a little bit of the phone tag that seems to happen more and more these days. So that's one option, and that used to be kind of our primary program entry, but what we've really shifted to pretty significantly in the last few years is a direct provider referral. We, over the years of establishing relationships with primary care, and what I mean by primary care is basically OB-GYNs and pediatricians. We established, and home visiting, established those relationships, and they consistently refer, but so many women aren't, for a variety of reasons, able to reach out on their own. So we've added in the last couple of years this direct referral options for providers, so that with their patients or clients' permission, they can refer directly to us, and then we will contact the mom or family from there. And we offer that in a few different ways. We have a secure, again, a HIPAA-compliant secure web form that can be filled out. We have a HIPAA-compliant fax that providers can send in. And then starting in 2018, we will be part of a cloud-based referral tool called CliniSync, which is part of the Ohio Health Information Partnership, which basically all hospitals use, that they can send us a direct referral, cloud-based referral. And then we can immediately let them know that we accept the referral and kind of what happens from there with their patient or client. So really just trying to, again, it all seems to, come from just looking at what challenges to care arise and what can we do to eliminate those barriers.
That's fantastic, and a great segue into the question about sort of the clinical program offerings and really how you connect with reproductive psychiatry, counselors, and others. Tell us about that and also how you proactively outreach hospitals, OBGYNs, et cetera, to make sure they know about the availability of these services.
Yeah. So as far as this professional referral network, starting with that, we've really shifted into serving sort of as this hub, for lack of a better word, the maternal mental health hub. So any home visiting program, any OBGYN, any primary care, anyone that's engaging women perinatal period initially. Essentially, it's a one call, we'll call it, and then obviously it's not always called, but the one call to resources is to us, and then we're going to do an assessment and figure out what's mom need, what does she feel comfortable, where would she like to start, and that's where then we figure out what's going on. Does she need access to a counselor? Does she need access to legal aid? What do those things look like, and we manage that from there. So this professional referral network, particularly with behavioral health, has been developed over many years, and we have both myself and other program staff, and then volunteers who we keep in touch with the clinicians who have specialized training and experience working in this field, and we track where they are in the city. Do they what insurance do they take? Do they take Medicaid? Do they, what's their wait time? We generally don't refer to anyone with more than about a 2-week wait. So we try to, we keep in touch because of that. So, and some we have to, give a phone number to a client here. Here's who to call. But all of our providers who provide Medicaid based counseling, we can do a direct referral. So again, we're trying to eliminate another call for a mom, so we can just make that direct referral, and then the counseling intake will call her and get that appointment set up. And we also, for moms with Medicaid benefits, we can do home-based counseling. Transportation issues in our city are also significant. So the more we can kind of eliminate that barrier that she has to try to find a ride or whatever to counseling, we do that as well. So again, it's just trying to function as this hub, this one call, and to whatever resources she might need. It's that honoring who she is at the center of she's the expert, and what can we do to help her connect. To get her on her way toward recovery.
That's great. I'm just going to pause for a moment and invite folks to send in any questions they have using the question feature on your GoToWebinar control panel. And as we wait for some questions, I see some familiar names. Hi, Kelly and Jennifer and Anne, and welcome everyone else. We want to hear from you, but Tanya, just again, I know those that are able to listen in are are likely very impressed with all that you've been able to accomplish, and really, recognize the importance of this partnership with Mental Health America and their partnership with the county, who is providing funds, and just all of the work that has gone into developing this program. Let me stop for just a minute and ask you, you just talked a little bit about home-based counseling, and I know you mentioned home visiting in your project submission for the award. That's really remarkable. I think several of us know about one of the great programs that Dr. Ammerman runs, where counseling services are provided in-home, but really I don't think very many others have tackled this. So can you talk a little bit about that for just a moment, in terms of the unique sort of challenges? Are they your own staff counselors that are going into the home, and then do you do additional training on how to prepare for going in the home, and what does that look like?
So no, that is all a partnership. We do not, the POEM program itself, program staff itself, really in the full Mental Health America staff here in Columbus, we don't provide any direct clinical programming at all. We are a non-covered entity. We follow some, several different ethical guidelines on HIPAA compliance and that kind of thing, more out of ethical duty and out of the relationships that we've built with providers. But we don't provide any of those clinical services ourselves. Those are all community partnerships, all either MOUs that, memorandum of understandings that have been developed, or just long-term, long-standing relationships. So the counseling agencies that there are about 4 that have clinicians who have maternal mental health training and experience, who are home-based, and those are the folks that we're in touch with a lot. We've developed this really positive relationship because they understand what we do. They understand the conversations that we're having with moms and how we're preparing them for counseling and that kind of thing. And we understand what they do. We know their intake staff. We know their names. So we're able to kind of start that relationship with the client as well. So the majority of the agencies who do that, they have case management on staff. So there's a lot of base knowledge that these agencies have already about what it looks like to be in the community. There's also just a really significant movement, finally, into community health, community-based care. What that means to to have community health workers and those kinds of things, in these subsets of our county. So, I'm not sure if that answers that, but.
No, it did. Thank you for clarifying that. It's not that your agency is providing direct service, other than the support group and peer mentor programs, which are not you're not billing for that time. So no, that's a great point of clarification and understanding. And the community-based organizations that are going in home, are they like Nurse Family Partnership and sort of the other home visiting type programs that the rest of us may be more familiar with, or are they more like mental health nonprofits that have trained staff? Do you mind sharing a little bit more about that?
So we sit right in the middle. Essentially, what we tell folks is we sit in between those nurse family partnerships, Help Me Grow, newborn home visiting, all of those programs that are home-based. What I call primary care. There are a number of health measures that those programs have to meet. Mental health is just one part of that. And what we do is we serve as that one call for those programs. So if anybody, Healthy Start is also, I think there are maybe 103 or so programs nationwide, so that might be one that people might be familiar with. So for the Healthy Start program here, that home visiting program, they're one that they do direct referrals. They screen with the EPS, and if they assess an issue, then they are automatically referring to us, and then we're contacting mom. Then we figure out kind of what she needs. Does she want to start with a mentor? Does she, a lot of the moms, again, transportation, she's not going to come to support group, but does she need connected to a home-based counselor? And then we can make that direct referral because we're tracking who's got what availability, and we're just not going to make a referral to a mental health agency that has a 2-month wait. You might as well not make the referral at all. So we sit sort of in the middle. I mean, yes, it's another step, it's another person to talk to, but like I said, for the programs like Healthy Start and Nurse Family Partnership, they have so many health measures to meet that figuring out what mental health agency has openings, who's got the specialized training to work with a pregnant or new mom, those are all things we take on for them. We take that on for primary care so that the referral, while it is one more step, is an actual quality referral. And we try to develop a kind of a mini, so to speak, relationship with the client, with the person that the home visiting referred, so that she knows we're going to make sure she gets connected. That we're going to follow up. We're going to continue to follow up with her until she gets connected and she's feeling like she has some. We do 3 different measures on symptom reduction and increasing coping skills. So we're going to continue to monitor her and make sure she gets connected and make sure that the connection is one that she feels positive about. And anywhere along the way, if she has other needs that arise, we've got that relationship where we're checking in and making sure that she's got what she needs.
That's great. Thank you for that. So it really is clear that, and more clear even for me now, Tanya, with your explanation, that it's really about care navigation, serving as a one-stop shop for women who are pregnant or in the postpartum period, and it sounds like sometimes even beyond, with some of your mentor programs for toddlers to teens, which is fantastic. That's really helpful. There are a couple questions that came in. Let me start with one that I know I have too, and so many organizations and community-based organizations that are trying to sort of figure out that warm line component. I know you're affiliated with Postpartum Support International. Tell us how does that warm line part sync up, since PSI also has a warm line? Does it just route calls to you, or do you have a separate number and you ask PSI to give it out, and maybe you're even serving as that volunteer and you give a different number than the national number? Can you talk through that a little bit?
Yeah, so I mean, we get a fair amount of either calls or emails from PSI's warm line volunteers. So if somebody calls, let's say, for example, somebody in Cleveland, Ohio calls PSI. They Google whatever and they find PSI. They're going to talk to a warm line volunteer, and a warm line volunteer is going to provide, what they do, which is that kind of initial social support, educational support, and then connect her to, Cleveland mom to a local resource, and, our number, our warm line or our support line, and our emails, those are what are listed on the Ohio page. So she's going to get connected to us through that. Conversely, mom could go on PSI's website, click on Ohio, and find our number directly. So that's what's listed. And then we're going to. Okay. So it's separate, but we get referrals from PSI. That people find us through there for sure.
Great. Okay, good. Tell us a little bit more about. And Kelly, thank you for this question. Tell us a little bit more about how you train the mothers who become facilitators of your support groups and or mentors. And I'm guessing you probably can kind of see some capability or leadership in them, even when they're not well, going through the programs that you're offering themselves, and sort of can bubble up and perhaps think about women that may be good for these programs. So how do you train them once they're identified or raise their hand to go through your program?
Sure. So we usually host a couple trainings a year. They're usually on Saturday mornings. we, like I said, we modeled the majority of our training after the Pacific Postpartum Support Society in Vancouver. I think postpartum.org is their website, if anybody isn't familiar with them already. And so they have some wonderful training materials that we did a lot of modeling from them. We also and that model looks like what does peer support mean? What does that mean? So we talk about boundaries. We go through a decision tree about how to share your personal story. That's a lot of how we gauge whether someone is ready. A lot of times women say they're ready before we get the sense they're ready. We have some steps there as far as doing a training and attending support group and and attending our maternal mental health group, which is again that one for moms beyond postpartum, kind of gauging their readiness for volunteering. But they have to do the training. They get a pretty significant training binder that has all of the elements of peer support, has the elements of, what does it mean to do active listening, that whole process of identifying, clarifying, what that looks like. Then, all the pieces about protocols, how we expect women to respond in a timely manner and that kind of thing when it comes to the mentor program. We do a section on group facilitation. What do group dynamics look like? How do you handle a problem? Those kinds of things. There are some elements from the mother-woman model that we've learned that we include in our training as well. And then we do a session, like a very mini session of what PSI's 2-day training looks like. We want our volunteers to understand the full spectrum of perinatal mood disorders, just like what clinicians get if they take the PSI 2-day training, so that not for the purposes of diagnosing or providing clinical advice, even if they happen to be a clinician, but not for that purpose, but so that they understand what's the difference between perinatal OCD and perinatal psychosis. What's the difference between what does depression look like and anxiety look like, and what's an intrusive thought, and just so that there's there's normalization of symptoms. There's understanding of what that looks like. So it's a pretty comprehensive training materials they get. Jane Honickman's book, I'm Listening. Again, that's all about peer support skills, if anybody's familiar with that. And then, the mentor program, once we develop that, serves as sort of a stair step. Usually moms will mentor for, anywhere from 6 months to a year, and get experienced in peer support before they become a facilitator. So, it's basically adding on what's peer support plus group management, and for anybody that manages groups knows that's no easy task. It can be challenging sometimes. So the mentor program usually serves as kind of that first step into peer support, and then the support groups. We have an online volunteer group page where volunteers can ask questions, or concerns or that kind of thing, and the other volunteers can answer questions. I mean, of course, I'm accessible. Our program coordinator is accessible. So we try to offer a lot of support. We do get-togethers a few times a year with all the volunteers to answer questions, and so there's a lot of ongoing continuing education that happens too.
Oh, good. That was one of the follow-up questions, is sort of continuing education once they go through one initial course to become a support group leader. Is there another course? And it sounds like there's maybe touch points and perhaps like a workshop or something like that. Does that sound about right?
Yeah, I mean, we don't have necessarily. We probably should have kind of follow-up workshops. We do always invite our trained volunteers to attend any of our new volunteer trainings, and then we have a late lunch, and we invite them to at least come for the last hour to do some kind of best practices and that kind of thing, and then it allows our newer volunteers to sort of hear, oh, okay, this is what these volunteers have experienced over the last year plus. We have some volunteers one that'll celebrate her 10th anniversary next year. So we do that, and then again we do the periodic get-togethers, and the purpose is, of course, fellowship, but it's also just informing them of new things. As we changed what our program looks like, moving from the support group centered into this kind of access centered, and building the relationships with the organizations that that serve moms with additional barriers, that serve, the moms who have Medicaid and such. Those were things that we've done conference calls and, and get-togethers, and saying, the makeup of the women we serve has changed over the years, has significantly grown, but has changed. So the circumstances in which women may be mentoring have changed. So we do, we're careful to inform our volunteers of things. But at some point, yeah, we probably should do a more formal, follow-up training. But it's kind of where we are right now.
Got it. No, that's helpful. And if you do have more questions about training and curriculum, and Tanya, I think maybe at some point we can talk to you all about your training curriculum and whether that can be made available, even if there's a charge, and we can help promote that curriculum. We'd love to get that in the hands of folks that are interested. It's all about not reinventing the wheel, right? When there's a model program that's working and working well. So let's circle back on that, and everyone on the line or listening to the recording, circle back with us later. There was also, there's a couple more questions about that, like how many hours is the initial training. I think we will just make those resources available down the road after we talk to you about how we might be able to make that happen, Tanya. So more to come on that.
Sure.
We do. There's a couple people that are talking about home visiting that might be available in their communities, including Diane. Diane, thanks for talking about some of the programs that are available in Austin through home visiting. And then there has been some interest in training that can be provided to mental health providers, even in private practice, for how they can bring their services in home, which is really interesting. So I think we can again tackle that offline. But anyone who's online today and wants to kind of continue that conversation, maybe we get a group of folks on an email string and to talk about that. Let me just also pause to see if there are any more questions for Tanya that we didn't cover, and then I'm going to turn it back to you, Tanya, to just tell us anything else that you want to share about your program. And in fact, I'm going to go ahead and turn that over to you now. I know one of the questions that came up from Samantha Meltzer Brody, who many of us in this field know and have so much respect for. She is the incoming president of the Marseille Society of North America, or also known currently as the Perinatal Mental Health Society, a partner in this program. She asked, what is your secret sauce? And I think she asked, it may have been you, Tanya, or perhaps another presenter, and I think it actually was you, and you said, it's really about relationships. There's no secret sauce. It's all very hard work, and this is built over time. And can you comment on that and just anything else that you want our viewers and listeners to know about how you got here and just that it's not necessarily been easy, just a lot of hard work over the years. Anything you want to share?
Yeah. I think it is a lot about relationships, if not all about relationships, about just being able to pause for a minute and saying, where are the barriers? We think so much about that. Where starting with outcomes and working backward. We want to figure out how do we support women in our community with mental health complications in, functioning successfully in their lives to the best of our ability, and starting with that and working backwards. What are the barriers? What are the things that aren't happening? And what can we impact? And it may not be all us. Like I said, we don't provide in-home counseling, but you better believe we've developed really positive relationships with those who do, and find out what do they need from us. What's the information that they need? They want us to make sure to securely send their Medicaid MMIS number so that they can process it quickly and give them a call. Well, absolutely. We'll make sure whatever we can do to make that as easy as possible. So it's just, I think that's where a lot of it has come from, is just starting with what's the outcome, what symptom reduction, increasing coping skills, meeting the needs that they have, and then just working backward from there. And that's where a lot of the programs come from. It certainly hasn't been, a quick process by any means. I think, each little piece and part has come about, a lot of times organically, sometimes strategically. The partnership with Mental Health America has certainly, been a big part of that. The pro bono counseling program that we have here is great. For when we can't get, someone into, they don't have Medicaid, they're not eligible, they're undocumented, they have, a high deductible health plan and their deductible is $7,000 and there's no way they can, they can afford counseling. So, and our pro bono counseling program comes in and helps with that. So, and that program was built, I guess about 6 years ago, to meet a need there with access to care. I don't, and I think there's a lot of really cool ways in which healthcare is becoming integrated, which is fantastic. There are a lot of new cloud-based referral tools that are coming up around the country, which are really cool, and we're excited to be a part of that here in Central Ohio. But that human element of maintaining relationships, I don't see that going anywhere anytime soon. Of being able to have a conversation with someone and make sure and that our clinical partners, who are just, like Dr. Melissa Brody, a hero to us all, doing life-saving work, they need to trust, they need to be able to trust that we're going to, if they're going to send them to a support group, that we're going to take care of mom, just like we know the phenomenal work that they're going to do. So it's that, it really is that trust and relationship, and that's really not a quick process a lot of times.
Great, that's wonderful. Well, we're scheduled for 30 more minutes. I think we're going to go ahead and wrap up. On the similar note, I think what we're hearing folks wanting just a smidge more information on, Tanya, is it's evident that this program and all of the amazing components that you've been able to build over the years because of your relationships and great communication skills and wisdom, that there is some evidence, like you're seeing great results. And can you just end on telling us, like, what kind of tracking mechanisms do you have in place to show that your program's working? And can we get our hands on whatever that looks like so that we can bring some of this information back to individual communities?
Sure. So yes, I guess I'll answer this in a few ways. One is that, for many years now, we've been, at our support groups, is where it started, and then it's grown to our mentor program. asked about more of that kind of satisfaction. How did you feel about the group? Was it helpful? Did you feel heard? How was it, did it help with you, your coping skills? Did it help, your mental health system seem less present? So we've been asking those questions of those attending support groups and that kind of thing for a long time. We reach out when our mentors close. When they complete a mentor relationship, our program coordinator reaches out to those who have used those services and asked similar questions. What we did to organize, I guess, it all is about 4 years ago. We applied for a grant with our city of Columbus Department of Development to expand the POEM program, and one of the biggest things that we asked for in that was money to build a database. So we built a custom database, HIPAA compliant, secure, web-based database that manages all of the demographic information, of course. Also manages what our referrals. So where are we sending moms? Did they get connected? And then we built within that, we have questions about symptoms and coping skills. And so when we first talk to a woman, we're asking about the presence of her symptoms. And it's sort of built around the same language as the EPDS, the Edinburgh Postnatal Depression Scale, so that if they have been screened, this is familiar language to them. And so we ask a little bit about that on our initial call, and then our database has a built-in follow-up on it. So as soon as she's entered into the database, it's automatically going to populate a date a week later. And essentially, as long as she stays active, we're going to continue to follow up with her, either as long as we can get a hold of her, or until she says, yes, my symptoms are reduced and I feel like I'm coping better, with my daily stresses. And it's just a click box in our database so that we can track an overall, improvement in coping and reduction in symptom. And it makes it pretty easy for us just to click those boxes to track outcomes. And like I said, we keep them active until and continue to do follow-ups. Now we can adjust that date. We're not harassing everybody once a week. They might say follow up with me in a month or whatever. But we just the way it's organized is that they're populated in order of follow-up. So we know who needs to be checked in on first and so on. Now it's not perfect. I mean, we don't, every person that we encounter, we don't, we have a lot of women that their phones get turned off. They're out a minute, whatever the case might be. So there are barriers and there are challenges that we continue to try to address. But that's a basic overview of how we manage outcomes. And I'm happy to share, I know there's a screenshot in one of the attachments of the database, but I'm happy to share other information about it.
Great, thank you so much for your overview. And just another quick reminder before we conclude today's discussion with our award winner in care, Innovation Award winner in care. There are a couple attachments, as Tanya just alluded to, in the GoToWebinar control panel. These are going to also be added to our website as links so that they'll be available indefinitely, but you can open those up right now. And there's also a drag and drop feature that's available through GoToWebinar right now, where you can drag those documents to your desktop and open them and keep them long term. If you don't do that before we conclude, that functionality won't be available once we end the webinar, but I want to make sure that you know that that's available. There's an overview. The very first document that Tanya has attached, or we have attached for Tanya, is a PowerPoint deck that provides just a little bit of information about her program that you've heard about today. There's also a provider questionnaire, and it really gets to how they vet who is qualified and who wants to be noted as a provider with expertise in treating maternal mental health disorders, and there is a focus on specialized training in this field, which so many feel passionate that is really critical. There's also an overview of what's provided to patients and providers about the free services the POEM program offers to everyone, the mentor program, the referral process, the support groups, online support, etc. Take a look at that. And then we have a referral form for POEM services. We also do have a screenshot that's not loaded here that Tanya alluded to about their database, and we'll make sure that that's available on the 2020 Mom website. I'm going to check one last time to make sure no new questions have come in. It doesn't look like it. We would love to encourage you to continue the dialogue. If you have more questions about this program, you're welcome to email us directly. You can use the email address info@2020mom.org, info@2020mom.org, and you also can see both my email address, it's Joy, and Tanya's email address on this slide. We're going to conclude with telling you about our next webinar in this series, and Stacy, if you can move forward, there you go. We're going to hear more about our Innovation in Policy and Advocacy Award winner on January 23rd, and then the next program in this webinar series is the Mothers Strong program, which is the Community Solution program, and Ann Dickman, and I think you're on today's call, is going to be presenting that webinar. It's the next one on January 11th. Mark your calendars and be sure you register for those webinars on our in this series. The information is on the 2020mom.org website. Tanya, thank you so much for your incredible work in this field. You really are exemplary in so many ways and contributing to the field and our communities in a really impactful way. Everyone, again, continue to keep the dialogue going. If there's anything of interest to you, we want to make sure you can adopt this model. This is what these innovation program award programs are about, helping communities to scale great programs that have evidence-based. Keep in touch, and everyone will talk to you all on January 11th. Happy holidays, and again, Tanya, thank you so much.
Thank you. Thank you.
Take care, everyone.